Welcome to the Comeback Lab podcast. This is your host, Dr. Melanie Worley, sports medicine physician specializing in regenerative orthopedics and performance recovery. This is the show where science, movement, and modern medicine come together to help you recover smarter, perform better, and return stronger. Each episode features experts in sports medicine, rehab, fitness, and human performance to break down the strategies behind real recovery and real results. Rachel Selman Let's build your comeback podcast. She is a physical therapist, strength and conditioning coach, and performance specialist with a background in chemistry from Georgia Tech and a doctorate of physical therapy from Mercer University. She holds CSCS and Performance and Sports Scientist certifications through the NSCA. She is also TPI certified in golf and has advanced training in pelvic health and running biomechanics. She also owns and operates an integrated wellness facility providing one-on-one care across physical therapy, training, and performance services, and she teaches courses on pelvic health, running, and postpartum recovery. She is the author of the first set of athlete-driven, peer-reviewed guidelines for performance in pregnancy and postpartum through the International Journal of Sports Physical Therapy, and is the author of the athlete-facing book, Floor It, Using the Pelvic Floor to Power Athletic Performance. Let's dive in. All right, so welcome to the Comeback Lab podcast. This is Dr. Rachel Selman with me. She's a pelvic floor physical therapist specialist, and we're going to talk today about running injuries and particularly the glutes and how we see a lot of pelvic injuries in runners. And so let's just jump right in. Give us a quick background on how you got into pelvic floor physical therapy and running.
Yeah, so I started in physical therapy, I think kind of like where most people start. Like I played sports growing up and had injuries. And so I'd been in and out of PT, had good experiences. And I remember I was probably in middle school when I was like, this is kind of fun. Like I enjoy being at PT, which I know is not a super normal experience, but also like the thought of doing that over something like a desk job where every hour is different and I'm in the gym and like we're moving was really enticing. So I went to career day with a PT in 8th grade. I've always known that I wanted to do PT. I think I was fairly certain that I wanted to do ortho and kind of sports medicine type stuff, and ended up at my first, job in a more sports medicine type field and setting. Stayed very, very ortho. Was kind of like, this is the only type of PT that I want to do. And then I had my first kid, and I was really frustrated through the pregnancy process because I was lifting and running and doing all these things. And well, to be honest, I wasn't doing a lot of running. I was doing a lot of lifting and had really found a love for resistance training. And so when I got pregnant, all of the kind of everyone's opinions come out of what you can and can't do during pregnancy, and people are very vocal about it for whatever reason. And I didn't know any better. I mean, I was pregnant in 2017. I think the first return to run guidelines that were just like an overview came out in 2019. And so I was navigating that at a time that we did not have the research that we do now, which was very, very frustrating. I constantly was like, is this safe? Is this too much? Is this not enough? And because of that, erred on the side of caution, lost a ton of strength in pregnancy that I didn't need to lose. And I had worked really freaking hard for, but was scared of lifting in pregnancy. And so, you have your baby and then it turns into wild, wild west of like, now there's no restrictions and everything's fine automatically. And from your field, like that's not how any musculoskeletal injury works.
Right.
So it was very like, everything was guarded and like very, very conservative during pregnancy. And then postpartum was the opposite. Do whatever you want, whenever you want, what feels good, what feels right, despite having a tear. And because of that, I had to navigate a lot of symptoms on my own that were incredibly frustrating, and the answers weren't readily available. And so I ended up talking to a friend who was a pelvic PT who I knew from school. I was in her wedding, like we were good friends. And it's unfortunate that that's the only reason that I knew anything about pelvic PT. But after going through some of it myself, I was like, God, this is so important, and ended up going and specializing in it. And so now that's what I do.
Amazing. Yeah. Thanks for that background. I think that's really helpful for listeners. As you can probably relate to, especially like in the elite running field, I know that there's a lot of pro athletes recently that have given childbirth and are kind of on their comeback, which I find it's really impressive. But also I think it's really important that we have some more guidelines for that patient population coming back to sport from pregnancy. So I think this will be a really fun episode to kind of dive in more into that. And so tell me too just about how you got into running for listeners and sort of what you're training for now.
Yeah, so with running, it was honestly one of those things where I think when something's taken away from you, you're suddenly interested in it. So again, when I was pregnant, I wasn't doing a ton of running at the time. I was doing a lot of resistance training,
Hmm.
but I followed the old guidelines of don't get your heart rate above 140, which I mean, I think a lot of people will understand if I did, if I breathed too heavily, my heart rate sometimes would be 140 in pregnancy. And so it went from being something that was on the table, I just didn't enjoy it at the time, to like now I quote can't run.
Hmm.
And so I think in pregnancy, when it was like, you can't run anymore, I was like, well, shoot, like I thought I really enjoyed that. And when I came into Orange Theory, I did postpartum.
Hmm.
And so I came in as a member and realized, hey, I kind of enjoy this. And it was kind of my time to get into my own space in my own head. And so I think that became more valuable to me after having kids, because it was a moment where I'm going to step out of the house, and for this run, no one's going to need me. And I have a very capable, very helpful husband, which makes a huge freaking difference. I think people are always like, how do you train? How do you do all this? I have a very supportive husband
Hmm.
who steps up and absolutely does his part. But he knows, like when I go on a 2-hour run, like you can reach me if you need to. I'm going to have my phone on do not disturb, but the only calls that are coming through are you. I'm going to listen to my audiobook, or I'm not going to listen to anything at all, but I'll still have my phone on do not disturb.
Hmm.
And so I think when I had kids, it became more valuable to me, one, because I felt like it had been taken away in pregnancy, even though it wasn't something I enjoyed at the time. But then two, having that space to step away, because again, you know what we do for work, you take care of people all day, and then you go home and you've got kids to take care of, and the second when you wake up, you're taking care of people. And
Hmm.
so runs felt like a way that I could take care of myself and still feel like I was kind of getting something done.
Absolutely, yeah. It's a great way to de-stress, obviously. For me, I'm like one of the only people that I don't even bring my phone a lot of times or even have music, because it's like my 145 minutes or an hour away from all of that, which is great. So definitely can
Totally.
relate. So let's talk more about the connection between the pelvic floor and glutes, and why should runners care about this?
Yeah, I think that this is something that until, again, very recently, we have not discussed. Again, the
Mhm.
first very initial postpartum guidelines for return to running came out in 2019. And that was not a peer reviewed paper. That said, the people who worked on it were incredible. It just wasn't in like a medical journal. It was kind of like a lot of specialists getting together and being like, we should start talking about this. And so we really owe a lot to them in that discussion, and that, guidelines for kind of tipping, into like, hey, we should look into this more. The reality is, from a muscle perspective, the pelvic floor is a force absorber, and running is all about force absorption and force production. If you cannot absorb force, you can't produce it. And so when I'm running, it's a bunch of single leg hops where every single hop, my body has to absorb force and dissipate it in a way that actually makes sense. And so if the pelvic floor cannot move up or down in either direction, or if it's stuck in one where it's stuck down or it's stuck up, it is one of those things where when I put my foot on the ground and I land with 2 to 3 times my body weight in terms of force, the force is going to go somewhere. So if my pelvic floor cannot absorb it, then it has to go somewhere that's going to tend to be my hips, my knees, my ankles, my back, kind of the area obviously around the pelvis. So I tell patients it's like a trampoline. We don't want a trampoline where the springs are so rigid that when I jump on the trampoline that it's very like jarring, but I do want enough give in the trampoline so that when I jump on it, it has a recoil. So I like go down to the trampoline, and then the springs are strong enough that I get recoil. That's very similar to what the pelvic floor should be doing in a run. So when I land, I expect that force to push my pelvic floor down, but I have enough control to where I don't experience like leaking or heaviness or pressure, which would be kind of like if I jumped on the trampoline and it had too much give. It
Mhm.
doesn't have the ability to like lower. So when my foot lands, my pelvic floor has to give, accept that force. And then
Mhm.
in order to produce that force to start my push into the next step, I need my pelvic floor to contract and support. And if it does not do that, then something else is going to, and that's going to be where we tend to see injuries.
Mhm. Yeah, I think people forget that running is actually a single leg sport, and that single leg stability is a big factor for injury. And I can speak from personal experience of that being a weakness of mine, which I think has led to a lot of the recent injuries that I also face. So, very good points. So, why are glute tendon injuries in particular so common in runners? And for those that don't know, what that means, maybe we can explain that as well. But the glute tendons, we have our glute medius and minimus are the two most important stabilizers for runners, and they attach at the outside of the hip at the greater trochanter. And this is often a source of pain and injury for runners. So I'll let you talk now, kind of why we feel like they're so common.
Yeah, I think that with tendon injuries, they're so common in runners because tendons are a little bit more stubborn than muscle. We can see pretty fast changes in muscle. And when I say fast, I mean relatively fast, right? In orthopedic world, fast is still a very relative term. But like I can see strength changes fairly quickly with athletes. I can see hypertrophy or muscle growth really quickly in athletes. I can notice, hey, last week you were deadlifting for 135 and this week we're doing 145. Like those changes can happen with smart progression and they can happen on a fairly quick timetable. Tendons are a little bit more stubborn. And so the reality is tendons don't have great blood flow compared to muscles. And then they don't have a ton of cells. So there's not like a lot of cell turnover. And so they take a lot more time to adapt. So a lot of my clients that are runners, what I see is they're actually really strong. I think there's a really great push for strength training in runners right now, which is really good to see because there's a lot of runners that don't like strength training. But they'll do strength training and they don't do any tendon training. And so they'll strengthen the muscles, they get stronger, they can produce more force, but their tendons can't handle it. And so when we leave out things like plyometrics or long isometrics that really mechanically load the tendon, then sometimes what we see is the muscle and the glutes are very responsive. They say, okay, cool, more load, we can handle that, we got this. But the tendon lags behind a little bit. And so that takes a lot of force that it's not quite ready to handle. I think the tendon's just particularly vulnerable to that. And especially in running, obviously, is a high impact sport.
Right. Yeah. Yeah. I think I see this a lot in my practice too, but too much volume too soon. I actually had a recent patient of mine who ended up trying to run a 100-mile ultra without any training. Like the longest run that they did it was pretty low. I think it was in the 10 to 15 mile range, which is not very much for a 100-mile race. And then they came in with a pretty acute, like peroneal tendinosynovitis, probably turning into a tendinopathy because there was already some pathology there. But anyways, definitely a load issue is what we see most often. So what are the early signs that people tend to ignore or misdiagnose in these cases?
I think the signs that people miss, and I think part of where we have failed in the physical therapy like side of things is us as a profession, we've become this thing where like a lot of people rely on us post-op or like post a very big injury, right? I'm very lucky in that I have a group of clients who are very proactive. I want them to call me or email me as soon as something starts hurting. I want to know about it. And sometimes I'll reply and I'll say like, hey, that sounds like, fairly normal for this point, because you can have some aches and pains with running that are very transient. That's just the reality of running. That's just the reality of adding to your training plan. I never expect that everything is going to go 100% perfectly. I mean, even again, as a PT, my running plans don't always go perfectly, right? There's still things that pop up and I have to know, is this something that I need to address or is it something that could just be transient and goes away tomorrow? And so I think as a physical therapy field, we have really messed up in not pushing ourselves as like, hey, I'm someone that you can come in, schedule an appointment, pop in and let me take a look at it and see if it's something that we could actually, fix before it becomes an actual problem. Runners in general, and you know this because you run, the reality is part of it is dampening down that pain signal in your brain because running is not always comfortable and that's how you get better at it. So like running fast and running hard and doing threshold work is hard stuff. And so you learn to dampen down those signals. And so you learn that that's what it is. Like running isn't always easy, but sometimes we lump pain into that as well. So my kind of general rules are if you have pain or soreness that dissipates very quickly within 24 hours on one run, no big deal, okay? If let's say my hip kind of bothered me that run, but it's gone the next day and the next run I go on, nothing's wrong. Okay, probably just some weird volume change. I slept bad the night before. I was dehydrated. I was doing something funky on that particular run. If I have back-to-back runs, even just 2 or 3, where I notice the same pain, despite, a day of rest or whatever, then that's where I say, like, go ahead and call me. Don't wait for it to linger on for 6 months. Yes, we can fix it, but it is much harder to fix it when it's been going on for 6 months. So a lot of my clients who will call me and say, like, my Achilles is kind of bothering me a little bit and it's done it for a couple of runs now. Okay, if we get you in, that's like 1 or 2 sessions. So again, from the PT side, we failed because we tend to make people think I have to have a very serious injury or I'm going to go in and she's going to tell me, gosh, you got to be in here 3 times a week for the next 12 weeks. Wrong. Maybe now, let's be honest, some settings still do that. But like the reality is for my clients, if it's a very acute injury that's just lingering a little bit longer than it should, a lot of times we can fix it before it even becomes an actual issue where they would need to go see you, right? So we can catch that on the early end. So those are my big rules. Like if it lingers for more than 24 hours, if it's hurting at rest, So that's a big one too. Like if I feel it during my run, but I stop, I rest, and I realize, okay, it's gone, it's not bothering me anymore, that's a great sign. We love them. But if I go home, sit down, prop up, and I realize it's still bothering me pretty bad, go ahead and come in. And again, I think that's a relationship with your physical therapist that you need to work on. We have our own primary cares. We all have people we rely on, but PTs, we kind of bounce around. I really encourage my clients, like, please reach out to me, like shoot me an email, and every now and then I'll reply and be like, you don't need me. This is good. It's fine. We just up your volume. No big deal. Stay in touch if it gets worse. And sometimes you need to hear that, right? As a runner, like, okay, cool. She said that was probably fine. But then sometimes it's me saying like, oh, I don't love that. Can we go ahead and try to fix it before it, derails our whole plan?
All good points. Yeah. I think getting in earlier is better from my own experience as well, just with my tendon issues that I've had. And I've had a bunch of PRP actually. Can speak to that when I'm trying to address it head on faster, usually has a better outcome. Even if you do end up needing PRP for the issue, it's actually still better to get the physical therapy treatment first, because that tendon's already experiencing some of that loading, so that the length of recovery is going to be shorter regardless, even if you do need more intervention. So what are runners usually doing wrong that's setting them up for this? I know we talked a little bit about that, but do you have any other specifics that you could talk on regarding that?
I think one is thinking is intuitive. With any other sport, we say like, you got to practice, you got to get better at it. You got to like kind of earn the ability to participate in these higher level activities. With running, it's a good thing and a bad thing that there's not as much of a gatekeepy feeling. Like I would never try to go pitch in an adult league softball game. I don't play softball. I've never played softball. I would need to practice a little bit before I did that. With running, there's a low entry point, which again is great in some ways of like anybody can do this. It's just something we have to kind of work up to. But in a lot of ways, anybody can do this, which is a problem, and we don't educate people on how to do it the right way. So like even just stuff like the zone 2 discussion. When I tell people like they're running too hard too often, their minds are just like, what do you mean? But it's not something that they've ever learned about. And I'm telling you to slow down, which doesn't make any like intuitive sense to you. And so I think one of the big kind of issues that runners face is like there's no like baseline level of practice or education that goes into doing this. And that is a great thing and also a tough thing. So if it's something that you're interested in doing, like I want to run, I want to be, a part of this kind of community. I think it's going to be interesting. I think it's going to be fun. I think it would be good for me. My number one recommendation is always to work with someone who's been there, done that. And whether that's a run coach or a personal trainer or whoever, someone that you know and you trust, sit down and come up with a game plan. I think that's a big one. And if you do that, then my second piece of advice would also just be to vary your runs. I think we mess that up a lot. I think regardless, when I first started running and you're just itching to go run, it doesn't matter what the distance is. It doesn't matter. I'm going to run the same feeling every single time, right? So if it's a 2-mile run versus a 6-mile run versus a 10-mile run, I'm going out there and working hard. By the time that I finish, I'm ready to be done and I want it to be over. So I'm running all of my runs at the same intensity and same volume and just changing the distances. That's not how tendons like to be treated. They want a little more up down, right? So I want an easy run. I want, one that's maybe more tempo based. I want one that's got some sprints in there because that's great for tendon health too. When the tendons are already healthy, can we keep them healthy that way? So again, if you are working with someone like a coach or a trainer or a physical therapist or DO or whatever who has a good experience and can give you some background, you're probably going to already get that advice. But if you choose to skip that step for whatever reason, my next piece of advice would be to make sure your runs look different. They should all look different. So in the course of a week, if I run 5 to 6 times, maybe 2 of them look the same, where I kind of have 2 just easy, I say like trots. I go on an easy trot, listen to like a calming audiobook if I listen to anything at all. I don't want to listen to crazy music. I have maybe 1, maybe 2 hard runs, and then maybe a long run. But they all look different. They all have different goals. They're all loading my muscles and my tendons differently. And in general, I think that that's what keeps people coming back to running, because it's different every day and being able to enjoy it without pain.
Yeah, the zone 2 is really important just from like an aerobic capacity standpoint too, in general, to build that engine. I think a lot of athletes and runners forget about that, how important that is. And then I run hard twice a week. So similar to what you're saying, trying to vary that, and then also making sure there's easy days worked in, as well as like a long run. And what are your thoughts on like the general guidelines when people are coming back from injury and we say like 10%, no more than 10% increase in volume? Is that truly helpful? Or do Do you have any different thoughts on that?
Yeah, I think that we relied really heavily on that. And I think this is also part of where it's really important for us as providers to be able to say like, hey, I'm willing to change my mind on that. Like, I don't think that actually had as much of an effect as we did. So even when I used to write running training plans, I was really big about like week to week, the weekly mileage is not jumping too quickly because we're worried that that's going to cause injury. The more recent research is going to indicate that like no specific singular run should be more than 10% what you've done in the past 30 days. So that's really what I look for is like a big spike in running, especially when we're talking about tendon or like bone health, making sure that, okay, in the past, 30 days, I haven't run more than 10 miles. That means I shouldn't be running more than 11 miles next, increase by 10. That takes patience. That takes time. That's not what people want to hear. If it's a beautiful day outside and I haven't run 12 miles in forever, the last time I ran was like 6 miles and that's the most I've done in the past 30 days, but I feel great today. I'm going to go crush it. That's where people get injured and it sucks. I mean, I get it. I did it last year, last April. It's that same thing where spring comes around. It was a beautiful day. I had not run long in forever, but I was like, I could be out here for, an eternity. It just felt so good. And that's when I hurt my shin. I started having a bone stress reaction, caught it early, shut down for 2 weeks, biked instead, and then it never came back. But had I not known that, had I not understood that that's probably what caused it, then that would have been problematic. So caring less about the 10% increase in weekly mileage as a total and caring more about what have I done in the past 30 days and whatever my longest run in the past 30 days, I'm not going to do more than about 10%. I also think that training baseline plays a role in that. So like if you've got a really long training history where you've been training for years and you have a little setback in 30 days, it's probably not as big of a deal for you to work back up a little bit faster. But if you're new to running or new to distance, someone who's training for their first marathon, then yeah, I would rather us be conservative and actually make it to the starting line than try to jump too far too fast to make up for, hey, I was really sick last month and I didn't get my long runs in the way that I should have. That's fine. I would rather work it up and be smart. There will be future marathons, but not if we create a stress fracture. So looking more at the past 30 days as opposed to week.
Good point. Yeah, for me, I come from like a sub 3 hour marathon background, and then basically I've had a lot of injury the last 3 years. And so my base went from like 60 to 70 miles a week to essentially like maybe I was lucky if I was running 10. So I've had to have a ton of patience recently as I increase my volume again. And I'm like around 20 to 23 miles a week, which is actually huge for me right now, which is great. But I plan to increase slowly. But it takes a ton of patience and you have to really hold back. Like on the long runs, I would love to go farther, but I'm waiting and just going very slow. So to kind of segue from that, what does good rehab actually look like when we're rehabbing a glute tendon injury?
I think when we talk about good rehab from the tendon standpoint in particular is load. I mean, we have to load the tendon. Tendons do not respond to rest. People see this all the time. I see it a lot in the podiatry world, and it's not to call out podiatrists, it's just where we are. And what I see is like I get sent people who have been to podiatry for Achilles tendonitis, peroneal tendonitis, and then they come in here and they've been in a boot for 4 weeks. And yes, it feels better in the boot because I'm not using it. But then as soon as I go back to using it, it feels exactly the way that it did before I even went into the boot. And so now I just wasted 4 weeks in a boot to feel exactly the same as I did when I went in. But you get the initial buy-in of, oh, it feels better because I'm not using it. And so you think, oh, this is working. And the second I try to go back to running, it's exactly the way that it was. And it's because tendons, we know, don't respond to rest. I think we used to, again, follow RICE, rest, ice, compress, elevate. Now it's largely the opposite. It's move and vascularize. So like use heat instead of ice and keep it moving instead of rest. And so especially when we're talking about tendons, the rehab has to look like loading. Tendons want mechanical load. So I always start with isometrics because they're great for pain relief. So get you in a position that loads the tendon, hold it for 30 to 45 seconds, hang out there, right? And that needs to be fairly heavy weight. A lot of times you can do that without increasing pain. So I look at, is your pain a 3 out of 10 at the start of the exercise and a 3 out of 10 at the end of the exercise? If that's the case, we're golden. If there's a small increase in pain, I'm okay with it. My general rule is like increase by 2 out of 10. So if we start the exercise as a 3 out of 10, but we end it at a 5, that's probably fine. If we start to push more to 6, 7, 8, probably not fine anymore. But tendons like load. And so sometimes there's a little bit of nuance of like, okay, there will be a small increase in pain when we do this activity. It shouldn't linger, okay? And I only want to increase by about 2 out of 10 at a time. So we start with isometrics, really long holds that what we know from the research takes those collagen fibers, it thickens them, it makes them more tense, it lines them up so that they're able to do their job. If we start with isometrics, one helps with pain control, reorganize the tendon, which is the actual issue, right? We know we don't call it tendonitis anymore because there's really not an inflammation component. So a lot of people come in and they think there's inflammation. They also don't understand why Advil's not working. There's no inflammatory response in these tendons. They've changed structure. And in order to change their structure back to what it was before it started bothering them, we have to load it to get it back to that structure. So starting with isometrics, spending a couple weeks there, really getting that under control, making sure that we're like minimizing any of that extra vascularization that comes with those types of things. Then move into eccentrics, concentrics. So these look more like your typical quote exercises. So full range heel raises, full range split squats, full range deadlifts, all that good stuff. And then move into power and speed and plyometrics. So now that my collagen is reorganized, my tendon is healthy, can it absorb force and can it produce force in a healthy way to keep up with my muscles? Because we know the muscles are probably going to be fine. It's the tendon, again, that lags behind, and that mismatch is what causes problems.
Yeah, you're speaking my language with everything that you just said. So the Rice model is really outdated. Unfortunately, we still see it a lot, especially like in the traditional sports medicine model and in my specialty. But we really need to start thinking about like not masking the healing and what's actually going on in the physiology like you described. And tendinopathy is such a better term than tendonitis for many reasons. But we know like that the collagen goes from like a nice type 1 collagen like you described to type 3, which is weaker. It looks thicker on ultrasound when I scan it, so the tendon will look irregular, it will look enlarged. Those are things that I will see on diagnostic ultrasound exam. And then we can talk a little bit more about this in a minute, but just that's where PRP also kind of comes into play with these injuries if it's not responding to the proper loading and rehab that you described. But all really good points. And I know we talked a little bit about some mistakes that we might see, biggest rehab mistakes. I think one is like too much load too soon. Do you have any other thoughts on that? And what other mistakes you see?
Too much load too soon. It's kind of finding that sweet spot. And again, that's where I think communication with your provider is so important. Like I tell people all the time, and I mean this kindly, especially millennials, because I'm a millennial too. We generally are driven to people please. And so sometimes I can tell by the look on your face, like maybe that exercise doesn't feel great, but you're not willing to like tell me about it. You have to. You have to. It's not going to hurt my feelings. It doesn't mean that I'm a bad PT. It doesn't mean you're a bad patient. If something doesn't feel good, I need you to tell me. I do not need you to nod and smile and like try to feed my ego. That defeats the purpose. And so I want to load it well enough that, like you said, we're reorganizing collagen fibers, we're improving the structure of the tendon itself. But there is a sweet spot of, again, if we load it too quickly, then we kind of backfire and the tendon's going to respond accordingly. And so I tell people when they first come into physical therapy, the window of activity is fairly small. There's this many things we can do from point A to point B that are going to feel good. Let's find those 3 things and let's focus on those. You know, isometrics. Okay, 3 exercises. We don't have to get crazy. Just do these things, do them regularly, and then things will change and that window of activity gets a little bit bigger. Now I can do this many things, right? And then over time that gets bigger, bigger, bigger. But if you go underload here or you go overload here, both of those things are problematic just in different ways.
And then, yeah, so for someone listening right now, like what 2 to 3 exercises would you recommend specifically for the glute area for runners if they only had a couple to choose from? Biggest bang for their buck?
Biggest bang for the buck right now, especially where I think the research is isometrics. I know I've said it a bunch of times, but especially when we're talking about tendon health, the research on that has been so good lately. And I've seen it personally. Like I've seen it personally work with clients. I've seen it personally work with myself. I love like a deadlift isometric. So a mid-thigh pull where we're in a squat rack. We have something stopping us from actually moving up into the deadlift, but we're still pulling against that force or technically pushing anyways. And so like getting into that range, trying to find and connect to the glute. I love a split squat isometric. All these, you can see these on my Instagram too. A split squat isometric is great because it helps me connect to the tendon. And so I tell people like, get into position, hold it, and see if you can feel what you're supposed to be feeling. Or is it other stuff that's trying to kick in and take over? Because if you can't feel it in a 30 to 45 second hold, you can't connect to that muscle, you're not going to be connecting it to it when you're out on a run. It's just not going to happen. It has to be subconscious by the time we get to the run. Right. So I love the deadlift isometric. I love the split squat isometric. I love the squat isometric. I love the calf raise isometric. Isometric right now is so great, especially when we're talking about tendon health.
I love the split squat, but also doing a calf raise in it because you're hitting both and getting soleus too because of the bent knee. So that's
Yep.
one of my favorite for just myself in general, but also for runners, I think, which is helpful. So now let's talk about at what point is physical therapy alone not enough for these injuries and when you might send someone to me for platelet-rich plasma.
Yeah, so I actually had a client like this recently that, again, you're not local to me, so I can't send directly to you, but like I have had to find providers here that I can send because part of our job as PTs is also acknowledging when we've gotten to a point that PT is not working. I think when we start in PT, we all kind of think I can fix everyone. And you know how it is. Like you want to fix everyone, you want to help everyone. But sometimes part of our job is acknowledging that this case is not going the way that it should be. And this is where I need to, refer out and maybe work an adjunct. Sometimes it's just refer out, call me back once you talk to them. Sometimes it's, hey, let's keep doing this, but I need you to go find them and work with them in the meantime. So for me, I look for lack of progression. So if we're working together, my kind of minimum is like 2 to 4 weeks. If we do 2 to 4 weeks of PT and we're not seeing change, I'm not saying it's going to be resolved in 2 to 4 weeks, but if we're not seeing improvement, that's a problem. And like we just talked about, there's multiple steps of tendon degeneration. And so when we get into those deeper layers of tendon degeneration, it's harder for us to kind of claw our way back out from the rehab side. And so, what we're doing in here is not going to hurt, but it's also not particularly going to get you back to a good starting point. So using PRP to kind of adjunct that. So doing things like the split squat isometrics, dry needling, cupping, anything that desensitizes nervous system and any of that new neurovascularization that can happen in a damaged tendon that makes it more sensitive. That's all great. But if it's been going on for a while, if I don't see improvement for, 2 to 4 weeks, then I know that generally I want to try to see if we can add something like PRP in to kind of speed up that healing process a little bit.
That's great. So you're kind of more on the early side, which I like, because I know some PTs will give it more like the 12 weeks or so, since the tendon can lag behind, but I kind of like that approach a little bit earlier. But do you have any thoughts on that in terms of waiting the 12 weeks or?
Yeah, I think, like you said, tendons are slow, and that's the problem. And, when we work in an insurance, I don't work in an insurance-based model, but when I did, the problem I would run into from the tendon health side is that, they'll say, hey, try, 6 weeks of PT, and if it's not better, then we need to take next steps. And I understand the thought process behind that, but tendons are so slow and steady that a lot of times I'm not going to see full resolution in 6 weeks. But the reality is from a desensitization standpoint, so again, a damaged tendon will also have that increased neurovascular status where it's like there's more nerves and more like fibers there that are feeding it and making it more sensitive. And so if we know that we're further along in that process, it's going to be more sensitive. And so if someone comes in, for example, and let's say they can't tolerate isometrics, like we cannot figure out anything that feels right, I need to go ahead and send them. And if I can go ahead and send them and get that process started, my job becomes a lot easier. They get better faster, all that good stuff. So we know tendons, again, are slow. So I understand the thought process of maybe we wait a little bit longer and see what happens. But I should, to me, and especially being out of network where people are paying a lot of money to come see me, I don't want to drag this out any longer than we have to. My job is to get you out of this office as quickly as I freaking can, right? Like with as few visits as I can. It's not a great business model, but it's also my job. I want you to be better and be out of here and not need me. If you are not seeing some improvement on the early end, let's go ahead and start this discussion. Because sometimes, too, we start the discussion and it takes clients a couple weeks to even be like, okay, fine, I'll go. Or, schedules are backed up. And so by the time I actually can get in to get it done, now I'm 8-9 weeks into physical therapy. And I can go ahead and get this done versus waiting until 12 weeks of PT where I'm still not really noticing a big difference. And now I've got to wait another 8 to get on a schedule and get be seen. And then that drags it out that much longer. So my general rule with clients is that if I'm not seeing tendon health changes in the first 2 to 4 weeks, doesn't need to be resolved, but better, then we need to go ahead and get that on board.
That makes sense, yeah. Yeah, so from my perspective, we see gluteal tendinopathy a ton, very common, and I also think it does excellent with PRP. I've had overall very good results for my patients where I've done the PRP injections for that. And I think one thing to highlight is that, if you're a physical therapist, you really should send your patients first to a non-surgical orthopedic specialist like myself, because we are skilled with diagnostic ultrasound, and that can be really helpful to see what's going on immediately without having to order an MRI. And then we can tell you kind of what our findings are, what our thoughts are, and come up with a team-based approach too. So you still might try to rehab it a little bit more first, but then if not, we kind of have a game plan going forward. We may need an MRI, depends on what the condition is. Usually for glute tendinopathy, you don't. Another thing that we could touch on, like not just the tendinopathy, but a lot of times there's little partial tears or micro tears, and that's oftentimes the reason why it may not heal with just the PT alone. And you already discussed how it doesn't have good blood supply, right? So the whole idea behind the platelets is that they have a ton of growth factors in them. There's like hundreds if you look at the list in our platelets. And one thing that they stimulate is angiogenesis, which is increased blood flow, and we have poor blood flow to tendon. So that's the whole idea. If we can direct it precisely in the area, so that's another thing that's important. It needs to be ultrasound guided right into the area of pathology, which you're going to base on, physical exam, but also the ultrasound findings. Then we usually can get these back to 100% with proper rehab afterwards in most cases. Occasionally, like you might need a second injection if you're like 50%, but if you're doing the PRP right and it's high concentration, oftentimes I find that one is enough in these scenarios. But curious just to see your thoughts on your experience with post-PRP rehab and how you sort of guide those patients versus non-PRP patients.
Yeah, I think it's one of those things that, like you said, it's really important that you're working with a team, that you're working in adjunct and understanding. I think part of the problem with healthcare these days, we're so siloed. And again, you want to be the person that fixes everyone, and that's just not how it works.
Yeah.
My job, again, is to get you better. And if that means that I need, a PRP injection on board to make that process a little bit smoother, why would we not do that? And if anything, my clients who end up kind of going that route are usually incredibly thankful because they realize, well, I do feel better. Because I feel better, I can better tolerate these exercises. Because I can better tolerate these exercises, now I'm actually seeing mechanical change at the tendon, meaning I don't notice symptoms anymore. Right. So, they'll go get PRP, which I love and support and think is a great adjunct and a great tool. And then because they do that, we can better, utilize our time in the clinic, as opposed to, sometimes when people come in and everything is so flared up and so irritated and so hypersensitive, we can't tolerate some things. I mean, like no matter what position I get you in, it hurts, right? Or everything feels good in here, and then as soon as you go home, you go back to life, it goes right back to normal, and we don't see that carryover between sessions. So that's, again, my 2 to 4 week rule of like, let's just go ahead and go get this process started. There's no reason not to. For most people, it's a financial thing. And so it's one of those things where like, okay, well, if that saves you this much in physical therapy visits and we tack that on and it's going to be faster, when we look at the plan of care from start to finish, that's actually probably a cheaper route than trying to chase all these little kind of like pipelines of this might work and this might work and let's try this for 6 more weeks and see what happens.
Right.
And so I think the PRP from a PT perspective, PTs who are willing to use that as an adjunct and again acknowledge that we can't fix everything, will notice that, gosh, it makes my job so much easier because now I can implement the stuff that I'm really good at so that this client gets better faster.
Mm-hmm. I always tell my patients too that I can inject anywhere in the body, I can inject their whole body, but if they don't go to a therapist and fix the biomechanics, you're not going to get better. And so I think it's really important. The combination of the two is what ultimately will get people back to 100%, not just the injection alone and not just the PT alone. It's both of them. And we also know that from the data, like we've already talked about throughout the episode, of just loading the tendon. That's with the PR, when you start to help the tendon signal to remodel, and then you load, that's the perfect combo because the tendon has the tools to remodel because of the increased blood flow, the platelets, the growth factors, but also because of the work that the patient does on their end to do that with you. So really important points. I could go on about this stuff forever. I feel like we did cover a lot though in the short amount of time, and I think it was a great conversation. Just going to ask a couple last rapid fire ending questions and then we'll let you get out of here. So what do you think is the worst thing that you can do with lateral hip pain?
Underload. Okay. Underload, which sounds again crazy, but the reality is that to me just drags the process out so much more. I think people start having pain. They think, oh gosh, I need to stop. I need to rest. And then an object in motion stays in motion. When we stop doing things, we have a harder time getting back into them. And then it becomes a whole ordeal. If I can just give you 2 exercises to be working on while you keep running, while you keep strength training, then a lot of times you're going to get better faster and actually be able to stay sustainable with what you're already doing.
Mm-hmm. And then what's one thing every runner should start doing tomorrow?
I'm probably going to sound like a broken record here, but one, I feel like isometrics is a key component. Isometrics on the other end of the spectrum is plyometrics. I have been avoiding plyometrics personally for a long time just because it feels like, gosh, there's so much to do. I can't do isometrics and plyometrics and run and strength train. Plyometrics are such a low-hanging fruit. So once you've done your isometrics and you feel good, your tendons are happy, 10 minutes of plyometrics 2 to 3 times a week. That's it. Like if I have a patient cancel, I run out the gym real quick, do my 10 minutes of plyometrics. Like you can get them in so fast. Things like jump rope, depth jumps, broad jumps. Now you can do specific guided programs where you're walking through various things over the course of 8 weeks. After 8 weeks, go back to the beginning, restart, and do it again. It's such a low-hanging fruit. It's a very fast turnaround on efficiency. So again, I'm like right on the cusp of that kind of Boston qualifying marathon time. And things like plyometrics are what can help take you that little bit forward with very little in return. So much of running is you've got to put in more time and you've got to do more work and you need more volume and more mileage. Plyometrics are not like that. And so I think a lot of runners think, I don't have time to tack on something else. It's so short, it's so effective, and it makes a huge difference for tendon health.
Absolutely, yeah. Even doing it for a warm-up, my High Rocks coach has been giving me those as well, like single leg pogo hops, double leg pogo hops, 8 skips, bead skips, all of that stuff. Really important and can help activate everything before you go out on your run. And then you also kind of killed 2 birds with 1 stone. So, and then last thing is, do you have a race that you're training for currently?
Right now I'm training for the Indianapolis Marathon, which I know is like a really big one. So if anyone's doing that one, I'd love to say hi. I've come across a couple people on Instagram who are doing it there. So I'm hoping to kind of like link up and say hello and wish them luck before we cross the starting line. It's supposed to be fairly flat. It's supposed to be decent. It's in November. So Indianapolis in November should be fairly cool. I'm about to train all summer in the freaking Southeast United States. So I'll be just absolutely miserable. But that first cool weather day that we get is a freaking dream. And all that like plasma buildup and everything that I have from the summer, it feels like I've been in altitude camp all summer, and then I get all the performance, benefits in the fall. So I'm hoping to utilize those, and fingers crossed that'll be a Boston qualifying. Well, you know how it is, Boston qualifying, but hopefully enough of a buffer to actually get to do Boston race.
Yes, yeah, I think you need like around 5-minute buffer, is it?
That's what I'm aiming for right now, because I'll be 35 in August. So my time right now is 3.5 hours. And so I'm really kind of aiming more for like 3:25 to feel a little bit more comfortable. But again, you know how it is, it's like every year they make it harder. I mean, up until this year, it was for me 3:35. And now I'm like, I'm going to get caught in that little 5-minute crossfire. Yeah. You just took that away from me and I really needed it. But hopefully the plyometrics will get me there.
I bet you can do it, yeah. Indy's a good race. I've heard good things, had a lot of friends that have run it, but it can be pretty cold. Where are you located currently?
I'm in Charlotte, North Carolina, but we moved here from Southwest Georgia. So we're used to the heat. I mean, it's starting to ramp up. Like even today I came back and I could wipe my face after my run and it's just like salt in my hand. But again, if I can make it through the summer, then usually there's like a day mid-September where I go on a run and it'll like tell me my pace and I'm like, okay, wait, that was all worth it. So I just have to keep that in mind.
I actually went to Wake Forest for undergrad, so I lived in Winston-Salem.
Yeah.
And my family lives in Wilmington, North Carolina.
Okay, yeah, very cool, very close. So you know the drill.
Yeah. And then lastly, if people want to find you on social media to learn more, since you have a lot of great content out there, where should they go?
Best place is definitely Instagram. So that's at dr.rachel-selman. I am a physical therapist. I feel like people get so weird about that. I don't care if you call me Dr. Rachel. That literally doesn't matter to me, but it is the title that I professionally have. So yes, it goes by that, but it says right on my bio, I am a physical therapist and not a medical doctor. So at dr.rachel-selman. I do have Facebook, but everything just pulls from Instagram. So, and then I just started a YouTube channel for more longer format content, kind of like this, because sometimes on Instagram, you know, you're limited. You've got 3 minutes or less to talk about very complex topics. So I just started a YouTube to kind of dive into more long content format, like answer questions for people, do case studies, that kind of stuff. And honestly, in terms of subscribing as like a follower, YouTube is the best kind of gift that you could give. Instagram is great, but YouTube kind of allows a little bit more creator freedom, and honestly they reimburse their creators a little bit better, and so it gives us more time to actually pour back into content for people who feel like they're getting something out of it.
Very nice. Okay, well, thanks so much for coming on the Comeback Lab, and it was great having you as a guest, and look forward to chatting more in the future about some running and injuries.
Thanks for having me.